Good evening, everyone. I'd like to say thank you for joining us tonight for our session 3 of our ANZ Virtual Venous Forum. Tonight, we will have some very good talks by some very prominent surgeons from around the world. I'd like to thank, firstly, BD and Phillips for sponsoring this session. I think it's very nice to have a sponsored session which is primarily driven by physician input and not by any marketing or behind the scenes pressures, which I would like to thank BD and Phillips for very greatly. So tonight we have some very interesting topics. We're going to talk about the inferior vena caval occlusion and the pathophysiology behind this, iliac vein reconstruction and stenting, confluence and IVC reconstructing, and results from post-thrombotic and chronic venous occlusion stenting. Tonight, our presenters will be Dr. Iman Bayat, Dr. Patrik Tosenovsky, Dr. Rick De Graaf, and of course, Professor Patrice. I can never get Patrice's surname. I'm sorry, Patrice, Mwipatayi. The first talk, of course, is going to be Dr. Iman Bayat, and we're going to talk about, he's a vascular surgeon who is down at the Northern Hospital in Melbourne, and his talk tonight is going to be on inferior vena caval occlusion and its pathophysiology. So I'm going to hand across to Iman right now.
Thanks very much, Steve, for the kind invitation and also for putting together this great program. Just bring up my slides. Now, okay, is this working? Can everybody see this?
We got it.
Beautiful, great. So I don't have any disclaimers in relation to this talk. My message to you is that Victoria remains beautiful and it's safe for both travel and complex venous intervention. Now, when we deal with IVC obstruction, sooner or later we have to face this sort of AP venogram. And to keep our talk clinically relevant, why don't we start here? And most of us would look at this and will say, this is the ascending lumbar vein, this is the azygous system, and we'll call everything else around here collaterals. And that's fine, but sometimes these collaterals take a more confusing picture and we don't like to be confused. And so why not take a few minutes to orient ourselves with some of these collateral pathways. So the retroperitoneum, the IVC and its branches as we know it, and our first collateral pathway, which is the azygous and hemiazygous system, which is the most important in this setup. And remember, we've got the 5 paired lumbar veins on either side of the IVC. They join to form the ascending lumbars on either side of the vertebral bodies. The 5th lumbar comes off the common iliac and usually becomes quite enlarged in these IVC obstructions. And let's not forget the ascending lumbar communicant vein, which is very important in drainage of that right kidney. Now, both of these veins have to leave the abdomen through the aortic opening. So they'll sort of come more anteriorly and leave through there and become the azygous and hemiazygous system and drain into the superior vena cava. The next system is our internal iliac, uterine, and gonadal collateral pathways. And here we have the ovarian vein leading to the ovarian plexus, the uterine plexus, and then they drain into the uterine veins, into the internal iliac veins in turn. Then we've got the portosystemic shunts, and one of the most important systems here is the anastomosis between the inferior and middle rectal venous plexus and the superior rectal plexus, which in turn drains into the inferior mesenteric, splenic, and then portal vein. When we've got occlusion of both the IVC and the iliacs, we rely heavily on our superficial epigastric and the inferior epigastric, which then join up with tributaries of the subclavian axillary veins in the chest. Now, in every case, we'll have a combination of these, some of them more pronounced or ones that are not named. And by knowing these, we familiarize ourselves with the anatomy a bit more. Now, why are these clinically relevant? let's come back to our azygous and hemiazygous system. As you can see, with the IVC lying on the right side of the vertebral bodies, it lies very closely in AP projection. It lies very closely to where the ascending lumbar is on the right. And in this exaggerated picture, you can see that they lie right on top of each other. And one of the areas where we don't want our wires and balloons to end up is down here, where we don't want to be going into the vertebral canal. And so it's very important to get a lateral view and be able to differentiate this collateral pathway from our IVC. And this is that same patient where you can see the ascending lumbar down here, and you can see the IVC would be up here in front of the vertebral body, and there we can direct our wires in the right place. Now, venous plexuses over time, they can develop into large single veins. And initially I found this quite confusing. I was like, what is this vein sitting in front of the vertebral body? And I couldn't find a name for it. And of course, that is your anterior external lumbar venous plexus, which over time can develop into a single vein. And this is a patient with atresia of the IVC. And as you can see, this large vein in front of the vertebral body, and of course it drains into the azygous system. It's not the IVC, and it's that development of that venous plexus over time. Now let's read a few verses from the Raju and Neglan scripture, which we must all read when we deal with IVC obstruction. IVC obstruction was really 2.8% of the work, and it's a large volume center. Interestingly, only a third had bilateral lower limb symptoms. The rest had single leg. 82% were infrarenal, 14% suprarenal, 4% extended into the chest. Only 7% were limited to the IVC. The rest also involved the iliacs. Now, 63% of these patients with venous ulcers, they healed. I think we'll hear more about this later in this session. And 90% of these patients had symptoms. There were only 10% who were asymptomatic. Now, what causes IVC obstruction? The most common cause is obviously thrombosis and post-thrombotic venous obstruction. And in terms of what the etiology of this thrombosis and post-thrombotic obstruction is, you can use whatever system that you're familiar with, whether you use outside the vein and the wall of the vein, inside the vein, or you like the Vercoe's triad, that's fine. I personally like this one, to divide them into congenitally abnormal IVC and congenitally normal IVC. An IVC thrombosis is very common in patients who have abnormal IVCs, although the prevalence in the community is quite low. Now, when we've got a congenitally normal IVC, then other factors come in, such as prothrombotic factors, thrombophilias, contraceptives, nephrotic syndrome, pregnancy, and of course, also abnormal pathology, such as tumors, Budd-Chiari syndrome, May-Thurner syndrome, and something that's quite becoming an issue is the IVC filters. Now let's look at congenital anomalies of the IVC. A few points here. Budd-Chiari syndrome seems to be the only one where IVC obstruction actually results in loss of function of the organs. You have hepatic failure, and this is likely because there's also hepatic vein stenosis in these patients. Atresia of the IVC or absence of IVC is very rare. Hypoplasias are more common, and the most common location is suprarenal and infrahepatic. We also remember the incidence of double IVCs, left-sided IVC, the azygous continuation of the IVC, and obviously abnormal placements or aberrations of renal vein anatomy. This is a case that came to us yesterday, a 51-year-old man with right leg pain, swelling, and discoloration. He had right iliofemoral DVT and a big tongue of thrombus going up into the suprarenal and, going into the IVC, and the outflow was by the hemiazygous. I'll just play you this video of their CT scan and hopefully guide it. But as you can see, there's this tongue of thrombus here up the IVC, and the IVC is absent above the level of the renals and below the liver, and all the drainage occurs up the azygous and hemiazygous system. So we took him to theater today, and we've put a thrombolytic catheter for the clot to marinate overnight, and tomorrow we'll take him in for angiojet to clear all of this. But while that's marinating, this is a case that I prepared earlier. This is a 42-year-old patient with atresia and hypoplasia of the infrarenal IVC, where we missed the boat initially. We didn't lyse his clot in time, and then he had to sit around for 18 months with fairly severe symptoms of venous claudication. And eventually we came to recanalize this, and we got access from both groins and the neck, snared the wires, and did kissing balloons, and used every stent known to man, the sinus XL at the top, the venites kissing in it, and the arbore down below the inguinal ligament. We were a bit concerned about the inflow on the right-hand side, and this is where IVUS is incredibly useful, where we can see the stent and its contours, make sure there's no stent compression, and then come down and see, wow, that's quite narrow. So we re-ballooned that patient, and 17 months follow-up, the patient is asymptomatic and the stents remain patent. Cancer and IVC obstruction, 37% of vena cava thrombosis, which involves both superior and inferior vena cava, is related to cancer. Cancer of the kidney and lung seem to be quite prominent. However, only 0.07% of patients with cancer will actually develop vena cava thrombosis. And we shouldn't forget that there's still a role for the knife and some proline suture, and this is a patient with an adrenal tumor that we resected, and they were fine. This is a 64-year-old lady with bilateral lower limb swelling and pain. They had a diagnosis of a follicular lymphoma in 2019 and had developed IVC thrombosis and bilateral iliac vein DVTs. They had 10 months of chemo and anticoagulation, eventually were in remission, but had an IVC obstruction. This is their angiogram, as you can see. And again, using the same technique, we went up and stented this. Here, I chose to use a completely Venovo system with by kissing two 12-160s into a 20 by 80 Venovo, and obviously concerned that there might be compression. We confirmed with IVUS and found there's very minimum compression of the stents within that KISS section. So I'd love to know what Rick thinks about this later. And 4 months later, it remains patent and the patient is asymptomatic. A few miscellaneous ones. Liver transplant seems to have an association with IVC obstruction and thrombosis, whether it's from the surgery or from the pressure of the liver that's put in. AAAs, whether it's the repair or the size of them, can affect the IVC. But something that's emerging is this IVC filter issue. Not so much in Australia, but I can see reports in the US where there seems to be a 25 times higher incidence of these stents filters going in there, and only a third are being removed. And we know that a third of long-term IVC filters thrombose. So obviously we're going to see more and more of these obstruct and to deal with them. And there are a few series out there about this. Coming back to that abnormal collateral pathway, this one confused me initially, and when I did some reading and found that it's the vein of Retzius, which is a connection between the IVC and the portal vein through the abdominal dorsal wall veins. At the end, I'd like to give a big thank you here to Rick De Graaf for supervising our first complex venous obstruction case at the Northern. I don't know if, Rick, you remember us, but you really kickstarted our practice, and this is what happens when you come out to countries and inspire people to do more of this. Thank you.
Thanks, Iman. That was really, really good. I think, all of these IVC anomalies that you find, if you find an asymptomatic IVC atresia, what's your mechanism and workup for these types of patients? Where do you go and what do you do?
It's a very good question, Steve. I didn't know what to do, and I sort of did some reading up. And again, coming out of the works of Raju and Neglan, they recommend that you put all of these patients on anticoagulation. So some of these patients, they consented and they stented. And some of them who didn't want to have a stent, they said, you're going to go on lifelong anticoagulation because of that very high risk of IVC thrombosis in these patients. So for example, that man with the vein of Retzius, that's what we did. We put him on anticoagulation, and because of COVID, he's a Cat 2 patient and he's been delayed. And we're hopefully going to get him into theater next Wednesday and do him.
That's interesting. Now, just for all the people that are out there who are involved today, there is at the bottom of your screen a mechanism that you can actually ask questions along the way. It's the Q&A tab down at the bottom of your screen, just next to, in that bottom panel. You can fill out your questions, and throughout the whole webinar, we'll attempt to answer these either via the chat mechanism or via discussion. But please don't hesitate to start sending in some questions so that we can quiz everybody on the panel today. So now I think what we'll do is we'll move on to our next presentation, then we'll just develop some questions along the way, Iman, and we'll keep it all moving.
Sounds very good.
Now,
thanks.
I'll just go back to here. Hopefully I've got the right one up. I think I have. All right. Our next presenter is Dr. Patrik Tosenovsky, who is actually a vascular surgeon over at Royal Perth Hospital and the Mount Hospital, Hollywood Private, St. John of God, and Broome Hospital. He's well known to everybody and has been doing venous interventions here in Australia for a long time. And he's going to be discussing about iliac vein reconstruction. So I'm going to hand it over to Patrik right now. Let's move along. Patrik, you there? Perfect.
Yeah, I'm trying. Hi, Steve. Trying to turn it on. Can you hear me and see me, guys?
Well.
Yeah, loud and clear.
Very good. Thanks for invitation, everybody. So my topic was iliofemoral venous reconstructions. And because I have published paper last year with details about how I do it, so I thought it might make more sense to show you some interesting pictures which can never be fit into any journal, like photos and videos, rather than explain how I do it, because anyone can read it now because it's free to download. I will show you first of all, patients I usually pick for intervention. So this is probably my typical patient with pigmentation, healed or even open ulcers. So it's usually C4, which I do. Very occasionally, I do patients like this one, where there is recurrent varicose veins, usually on the left side, which suggests that there is central venous obstruction. But most of those patients, as you can see, are those with terrible or advanced chronic venous insufficiency, usually C3 with pain or C4 and higher up. In terms of pre-reconstruction imaging, I try to do more MRIs, as you can see on the left-hand side, which sometimes shows very nice picture, like in this case, left common iliac vein obstruction with huge collaterals in the pelvis. But most of the time, I still do CT scan. So on the right-hand side, you can see the CT venography. This is what some would call direct CT venography because the contrast was injected through the femoral vein. And you can see two areas of compression in this case. In some cases, I do injection myself in theater, and I do CT dynamic angiography or DynaCT. And on this picture, you can see compression of both common iliac veins with some collaterals in the pelvis. In terms of reconstruction, we should probably all of us do venoplasty before venous stenting, because if we do venous stenting, it will look like on this picture, where the stent did not open nicely, and those fibrotic lesions will still compress the vein, the venous stent. So venoplasty and stenting, that's probably how it should be done. In terms of placing the iliac vein stent, there is a lot of confusion in amongst the physicians how to do it precisely. And despite of the fact that I have done many, I sometimes am very surprised where the actual compression is. And I have to say that IVAS helped me a lot, and I have learned during the last few years with IVAS, when I was comparing IVAS with venography, how different the location of the actual compression or obstruction can be. So in this case, you can see poorly opacified distal IVC with left iliac vein compression mainly. And mind you, this patient was presenting only with the left lower limb symptoms. This is after IVAS was used, and the marked level of the on the screen showed where the actual right iliac artery was tightly compressing the left iliac vein. And as you can see, I have used in this case sinus obliquus stent, and it's still, in my opinion, very high, almost in the IVC localized compression. So with a regular stent, it would be hard not to touch the opposite wall. And this is completion angiography. So, I would summarize this slide that venography almost never shows precisely where the location is. And that's the reason I like IVAS. Sometimes it's probably a good idea to have a look what we did, and the compression of the left iliac vein can look in lateral view like this. The stent still can be significantly compressed, and on venography in AP projection, it might look completely normal. It's also important to realize that there are different stents available, and in my opinion, different pathology in different location and different pathophysiology should prompt us to use a different stents. Although I know it's hard sometimes to have available everything for one patient. This is how it looks like in the cath lab where me and Patrice working. This is the Royal Ped Hospital cath lab. I tend to use the normal transcutaneous ultrasound for all my cases, obviously fluoroscopy machine and IVAS. And if I can, and if the pathology allows me to, I tend to use also either RFA for superficial veins or laser or glue, depends on what I need to do. So pretty much everything on one go. So typical patient would look like this, C4, maybe C5, as I can see, healed ulcer on the left leg, with pathology in the superficial and deep vein system. And I use two axes, one for great saphenous vein and one for femoral vein. Obviously, the femoral vein is for venography, IVAS stenting, and the great saphenous vein for ablation. And the patient leaves the room completely fixed from deep and superficial venous perspective. I know that Iman was discussing the IVC pathology, but I just had one slide to show that the access for venous reconstruction of IVC is slightly different. And I use general anesthetic for all patients. I use access from both femoral veins and from jugular vein almost routinely for IVC reconstructions. And because it's a long procedure, it's handy to have them prepared like for major vascular operation, including heart assessment. A few slides from the open side. This is, for example, common iliac vein stent, which was opened 4 months after the implantation, and I just wanted to show you how the stent in iliofemoral segment nicely re-endothelialized in 4 months. You can barely see the struts, and this is the reason for the reopening of the femoral vein was that the reconstruction was gradually failing, and the flow was slowing down, so I had to improve the inflow. And this is the magnified segment of the cut off stent from the femoral vein, and you can see how beautifully those struts are covered with a new endothelium only 4 months after implantation. And this is a similar case where the stents was cut off the IVC 2 years later. The patient was scheduled for left renal vein transposition, and because the original iliac vein stent was too long, I managed to cut off. And I just wanted to show you how the free floating segment of the iliac stent sitting in the IVC is endothelializing from outside of the struts towards the center. And I'm sure that a few years later, it is completely covered and sealed. And in cases we gel the contralateral side, it makes the difference. In cases where I have to do both iliac vein stenting, I know that Rick will be talking about it in details, but I have one slide that I wanted to show you. I've learned that, you know, those stents, some more than others, can cause troubles like pushing the other one, or even compress it, or they can buckle up. And the IVUS can show you nicely, you know, what you've actually done, because the flow during venography is almost always beautiful, and it doesn't show the details how those stents can be compressed, and in this case it is more than 50% stenosis. And in terms of IVC imaging, I have learned also that, for example, in people under general anesthesia where the machine is breathing for them, the collapsibility of the stent is not as bad as under local anesthesia and sedation, but it can still be quite dramatic, as you can see that the venous lumen or cross-sectional area collapses, down to 30, almost 30 square millimeters from 220. I know that this IVC is slightly smaller, but even though it shows how different the venous system is in compared to, say, aorta, which remains essentially stable size all the time, regardless of respiration. And interesting picture from the CT scan. On the left-hand side, you can see the proximal segment of the IVC with the stent about a year or year and a half after recanalization. And on the right-hand side, you can see the same patient with completely collapsed stent, and the patient was re-referred back to me urgently from the radiology, saying that the stent, which I put in 2 years ago or a year and a half ago, collapsed completely. So the patient ended up on operating table with me doing venography, and only during the fluoroscopy I've learned that the stent collapses completely during the cardiac cycle. So it's no pathology, it's just unfortunately that this patient was caught in the CT scanner when the vein was collapsed. So it's normal finding. And the last thing I have for you is to show you very brief video sequence of redo surgery of the groin after iliofemoral vein stenting, which needed thrombolysis and improvement of the inflow in terms of endophlebectomy. I hope it's going to work. So this patient represented with thrombosed iliofemoral vein stent, which I have decided to cut off because in this case, the inflow was the issue. So I wanted to improve inflow by cutting the stent off the common femoral vein and subsequently patching it with bovine patch. And I just wanted to show you, because it's not something we see every day and something we don't want to see every day, how the stent 1 year after being placed in to the common femoral vein looks like. Mind you, it was placed inside of previously thrombosed segment of the femoral vein. And the rest of the procedure is quite straightforward with the patching of the common femoral vein, and hopefully then successfully stenting the iliac segment or iliocaval segment. And that's pretty much all from my side today. This is only a few more seconds of the video.
That's pretty interesting. Patrick, can you tell me how difficult was it to actually remove that stent from your common femoral vein? Because in my experience, they've become extremely incorporated and very difficult to pull out.
Yes, I agree. I found the endophlebectomy difficult, full stop, even if it's primary procedure, and secondary, as you can imagine. And as you said, it's not much fun, and it takes most of your day, let alone the post-op, recuperation of the patient with lymphatic leak and associated complications like a wound complications mainly.
Yeah, Rick, what do you think about having an obstruction such as that in the common femoral vein that's been stented? Do you routinely try and pull things out and do an endophlebectomy, or do you leave it alone or attempt something else?
Well, endophlebectomy is not really my thing, as you know. I used to do that, of course, in Maastricht, but being an interventional radiology, I just don't have that specific quality to do that. So I try everything to, first of all, I think it's very important to go step by step and not really get yourself into a position where I cannot solve it anymore. And I must say, I'm now a little bit more careful after the years in Maastricht, where I always had the backup of a very good vascular surgeon, very experienced in venous disease. And I now look in the mirror a little bit more like, should I do this? And I'm a little bit more careful. And I'm also talking to the patient that way, that I say, okay, maybe we should not do it now and prevent ourselves from making or causing problems that I cannot solve. And maybe in 5 years or 2 years, there will be something that I can offer then. So yeah, but I'll go as far endovascular as I think it's possible.
Yeah. What's the other thing I found with your talk, Patrick? I thought very interesting how you're getting endothelialization of the cell structure about the stents, which are crossing over into the opposite side of the IVC. Has anyone else found that in their experience?
So I didn't, and I'm very thankful for those pictures. I mean, we come so long, or we come so far, right, over the last years, and these pictures and these things that Patrick is doing, and Patrick I know for a long time, an excellent surgeon, and really thinks further and further and further. And what can you do? These pictures and this knowledge is so important for us to see what actually is happening, because we've been talking for years and years on what might happen, what might be. Thinking about specific stent design and should you use that stent because that might endothelialize and that one might not. But now we actually see what's happening, and I didn't see it before, and I think it's absolutely brilliant information that we absolutely should use.
Yeah, these explants, I got to commend you, Patrick, pulling out some of these stents and actually having a look at them. It's really valuable information. We were only talking about this last week about how crossing across into the IVC and obstructing flow from the contralateral venous inflow could lead to a contralateral DVT. But I used to think that it just used to be related to a closed cell stent structure, such as the wall stent, not the new stents that we actually deal with. But in seeing your pictures now, it's obviously that we are getting endothelialization of some of those stent structures. Yeah.
I'd like to jump in here as
yeah.
well and say.
Sorry.
Hang on. One person.
Sorry, Patrick. I was just going to say, I'd love to have those pictures as well to show my patients. You know, these cases of atresia that come in and there's almost nothing there, and we put two 14 by 14 balloons and pre-dilate. We're obviously in the retroperitoneum, and we put a stent in that location, and the stent remains open. And obviously, this is what's happening. They're getting new intima formation, and having that picture to actually prove it is wonderful. So thank you.
While we've got you there, Iman, there's a couple of questions that were directed to you from the previous chat. One of them was that, is the best investigation a CT venogram or a diagnostic venogram when looking at the IVC anomalies? What do you think about that?
I think you need all of them. You need a cross-sectional study like a CT venogram, or if your center is set up to do an MR venogram, that's good too. The CT venogram has to be timed well. In our hospital, Dr. Terry Koch, he's terrific. He gets the cannulas in the ankles, and we put compression on the legs and really get that good flow up of contrast into these veins and get good pictures. And obviously, when it comes to the intervention, use venogram. So I use both. I almost never go into a case without having some cross-sectional imaging. What are your thoughts, Steve?
Oh, I was going to ask, Patrice is sitting there. I was just going to see what Patrice does as well. And Rick, what do you think? What's your algorithm?
Well, you know, Patrice has not yet activated his microphone. So you know me. I'm a big fan of MR. MR shows you everything, and also that idea that I might be very happy with the talk from Iman. Also, that says, okay, a absent IVC is extremely rare, if not existent. And MR will always show you some little remnant or fibrotic canal, and MR is I think definitely way better than CT for that with the different sequences that we use. So MR is absolutely always. I will always run an MR for IVC or actually iliofemoral obstruction as well.
Patrice?
Yeah. I always get a CT venography, and I see that Patrick get the MRI venography, which is fairly challenging for us to get in some of the institutions. Mostly at Prof, they seem to be giving us a bit of problems all about the rebate and all those things. But one of the things that Patrick said, which is very interesting, because when I do CT venography and I'm still not happy, then I do a Dana CT venography. Then I've done few Dana CT venography on patient under GA versus patient under local. And I've seen that the effect of the collapse of that IVC as well. But then I reset it again and asking the patient to take less deep breath in. Then you see the IVC opening. So, but those are the young patients with good renal functions and which you are really keen to do something as reconstructions.
Mm. Rick, can I ask you, I mean, for here in Australia, we don't have ready access for MR or MR venography. If we were to ask our patients to go and have an MRV somebody or somewhere at a practice, can they just do it off the bat, or do we have to ask for specific things, specific sequences? What information and advice can you give us about what to ask our radiologists here if we're attempting an MR?
Well, we'll definitely need some specific sequences. But, you know, an example. So I've been talking about it for years and years, and Maastricht had most beautiful pictures, that's always been said, right? And it was so difficult to get that protocol running, and everybody said that. So I moved to Frieshaven, just a general hospital with no experience in venous whatsoever before. And I just took my protocol with me. I gave it to a dedicated radiologist and our technician, and bang, it just worked perfectly, right? exactly the same picture. So of course you need certain parameters, but you can just get them now from the internet. I mean, it's fairly easy. You need some dedication, and you will run it. And of course, the Thrive that we use is beautiful. You know, we have it all stacked up from the pop digital all the way up to the heart. But with a very simple balanced sequence, you can image the abdomen and pelvis perfectly, and you will see if there's thrombosis or post-thrombotic disease, you will see it very, very accurately. So I think there's some kind of magic around that MR that's difficult, but in fact I don't buy it. I think it's really, you know, just do it.
I might ask you if you would mind providing your sequence or protocol, or is it a special KFC recipe that's secret?
No. Only when I can deliver it to you in person. No. In a briefcase, you know, on a lock, I will give it to you. You have to sign. No, of course, okay. I will. I don't have it really. I cannot find it in 5 minutes, but I will supply it without a doubt.
That'd be lovely.
You know, I have to imagine that's for a Philips system, 1.5 Tesla. But of course, there might be other systems, but you need to, you know, there's a technician. My God, they learned how to do it, right? So they went to school and everything, so they should be able to twitch that together with the company of the Siemens or whatever to make it work. You know, motivate with alcohol and chocolates, Steve. Motivate.
I'm there, and when you come over, there will be red wine, alcohol, and I have these new butterscotch and chocolate lollies for you. Beautiful. There's a couple of other questions just before we move on to your talk. There was one, this is for Iman as well, and probably for Patrik. What's the role of IVUS in the treatment of IVC atresia? What do you think about that?
I can start the chat. I think, well, stent sizing is very important. It gives you an accurate measure of the caliber of the vein. It also can identify little webs that sometimes on venography are not clearly visible. When you're pulling them down, you just see them as webs there in the IVC. Also, for where you want to land your stent, especially if you're landing in some chronic venous disease, you want to make sure that you have a patent good inflow coming into that, and that's always a great use for IVUS. Those are the three that I can think on the top of my head. Patrik, what are your thoughts?
Yeah, I agree, Iman. What I use IVUS for is mainly non-thrombotic lesions, because I can't see them without IVUS at all. And for post-thrombotic, I use it mainly for post-stenting, to make sure that I have stented everything that I wanted to stent. So it's sort of like completion thing, because if it's, you know, post-thrombotic, mainly occluded segment, I don't see any, you know, role of IVUS pre-ballooning. But I do use it if I'm not sure about the landing zone. So if I can see, for example, common femoral vein with IVUS, I do it beforehand. So mainly for post-thrombotic after intervention, I would say.
Okay. With that, we're going to move on, and I'll share this again. We have a distinguished guest, Rick De Graaf, who we all know from international conferences. He's been over here in Australia, has given multiple talks and advice to all of us, and we've all found his advice refreshing and very, very enlightening. He is going to talk to us today about confluence and IVC reconstruction. So I'll hand it over to you, Rick.
Perfect. Thank you, Steve. I will try to share my screen right now, so that will work in a second. You probably see it, right?
Got it.
I think so, right. So I wanna start by just thanking the former speakers. It was excellent, Iman. It was absolutely beautiful. That makes my work now a lot easier the next 15 minutes. And of course, I remember our time back in your place. And as I said, back then, I was amazed about your professional setup of the whole of your practice. That was amazing. I'm still remember that vividly. Remember the surroundings also, actually, and how beautiful that was. So I would rather be there at this moment. But what I do not remember actually how I was sticking out above you guys with my big head. That was pretty confronting just now. So anyway, let's start and talk about confidence in IVC reconstruction. And I think that a true IVC reconstruction without a confidence is rare. So far, since I've been here since 2.5 years, I did it twice. One with a short IVC, complete obstruction and a large aneurysm. But in most cases, you will need to also think about the confidence to reconstruct. So this is how we set it up. Nice simultaneous flow to just see what's going on at all. Yeah, in this case, it's fairly simple. You know where we need to go. With the wire and the catheter. Show a little handy here. Of course, these collaterals might also project in a different way. And you see here that where you should go, we should here, we should go. Sometimes it's completely occluded, right? So you don't know exactly where you need to go. And then that bilateral angiography, what looks nice, is of course without value. You have to take different projections and look again and look again. Here with my catheter, I can fairly easy go up this vertebral catheter. Of course, I always look in different projections as I just showed you. And what I'm going to do in a minute, because the wire is continuously going in a different route, I will do a angio and take a roadmap out of that. This is something that I do not generally do with an occlusion. I know that, for example, Niels Kruger said always, that he's when he cannot get any further with the catheter, that he will do a contrast injection. I think that's quite dangerous, because if you're not really in that tight canal, then you can create an extravasate, and then you don't see wires and catheters anymore. In this case, it's not a big deal. It is obstructed, yes, but it's definitely not occluded. And with some simple techniques, you will be able to run your wire and catheter cranially. Sometimes you need a glide catheter or some CTO. We have so many things at our disposal at this moment. So it's not, it's getting easier and easier. So now you see that with a wire, I'm through the into the IVC. And I can just exchange for a very strong wire. Sometimes, if a balloon doesn't go up, then you need a body floss technique. But in this case, you can just push, inflate a large balloon directly over that stiff wire, and like 24, 25 millimeters. And oops, we got a problem, because I didn't check. Well, in this case, I did check. Yes, there's the collateral, the varicose vein that Iman was talking about. And if you're not accurate, or you're arrogant, or too experienced, or whatever, or less experienced, everything is possible in the cath lab, or you have a tea time or something, then you inflate an varicose vein. So not a big deal if you understand what you're doing. So pull back the catheter, see where the IVC actually is, go with the wire up, and then inflate the whole thing till 24, 26 millimeters. I like to go big. So these are, this is from a publication for years ago, I think 2018, based up on Necklin, where he talked about the double barrel technique. You only had wall stands, and also a position technique was proposed, and a fenestration technique. Oh, please forget about these two, because it's just horrible. We don't do that. I don't know any serious interventions that does these kind of things. So double barrel is possible. However, back then, I liked the thing that had been showed before. That's the large IVC stent and then get with the 2 self-expandable stents to enter that stent, and thereby creating a new confluence, if you will. So I was very happy with that when I started. Looked very nice, you know, large stents, and you really reconstructed the IVC and then the self-expandable stents inside, and look how great that was. And then the angio, and it looks fine, and everybody was applauding, and that it was looking all good. However, many things here I didn't know. This is something that I really want to point out. This is not good. It looks like this is a normal IVC. It is not, or I implanted a too large stent. And over the years, I've seen problems existing here because the stent moves in and you have, again, a stenosis or an occlusion. This is not a good thing. In many cases, almost in all cases, I go up to the hepatic veins and land the stent like, you know, like the Venous stent, really like a flaring that looks great, and thereby the stent relaxes itself, and the problem is not occurring like I don't show you here, but you can imagine. So there are other cons. First, the pros. So large stents inside, there's no skip lesions. I don't know if skip lesions really matter, but there's always talk about that. We should not have skip lesions, definitely based upon the literature by Necklin. Of course, you use fewer stents, you know, but you don't have the double barrels configuration, and you preserve stent integrity. So that's all good. But the cons are these nice examples where I truly believe that it will happen over time. There is not enough place not even in a 24 millimeter stent to have 2 14 or 16 millimeter stents completely nicely dilated. And what will happen if one stent is slightly bigger than the other one? That will win. That's the principle of self-expandable stents. They're stronger when they're a little bit bigger, so they will push. Sooner or later, they will push that other stent closed. So, yeah, probably only use closed-cell stents design, so that's not a big plus. And you have that kinking thing, you know, because the anatomy is different. You have the right side is going straight up and the left side is going like this. So the stents are always moving and working against each other. That's not a good thing, in my opinion. So then almost falling asleep, although it's still morning here, so I should sit up. So the other thing that you can do is have the large stent up and have a touching technique where the stents are not really inside that large stent, but just touching. That would be a good thing, right? Because then the stents, the ILIAC stents have their possibility to just deploy itself themselves and not you know, interfere with each other. So the problem that exists is that sooner or later the stents will straighten. And no, that's a theory. It's a nice theory, but it's also practice, because if you see here, it's a nice large vena cava stent. There's a stent from the right side. Oh, the stent from the left side is going straight through, and that is not a good thing. Trust me, they were in good place before. So yeah, that does happen. And again, because of the configuration from the left side. So then and a nice thought, okay, a balloon expandable stent confluence, that would be fun. We published that, and we took some very large stent. We should crimp on the balloon, and we really felt like an interventionalist from the early 90s, you know, where we had to do stuff like that. So that was a good thing. And it also looked very, very nice. You know, you position those balloon expandable stents, and afterwards it was a beautiful confluence, and it's very expensive though. So that was a negative, but it looks really nice. If you can see here, nicely open stents, and just looked perfect. I thought back then. The problem is that of course, when you treat, for example, a young female might be pregnant, some compression along the way might always happen. And as you know, a balloon expandable stent, once compressed, will never open again. So that was an issue that we saw a couple of times, and you don't want to see it once. So I abolished that technique. Although it looked nice, I abolished technique. I didn't want to do that anymore. So what came then on the market? The oblique stent from Optimed, long time no see. These are these stents. They were designed to actually place exactly on that on the confluence from the unilateral side. Well, if you do it like this, then I thought, okay, so there's no interference with these stents. You have a small skip lesion, but shouldn't be a huge problem. I thought it really was a nice configuration, and you have also that durability in there. So it looked like this, and just look here. There's no interference with stent material whatsoever. Just continuously go into that large vena cava stent. So I really like that one. I really like that one. The problem is not every person is the same as you. I just skipped over that. So it looks very nicely like this, but it might look like this when the anatomy is a little bit different. So that might be an issue, but for the rest, it looks very nice. Again, expensive though. So after all that, and thinking about different configurations and different stents, and being from expensive to more expensive to everything has been thought of. I have to be honest. I think I lost a lot of time, because I think the double barrel technique that actually was presented by Necklin years and years and years ago is a very, very nice thing to do. One side might occlude and doesn't obstruct the other side. So it is a nice thought. Still, with the modern stents, you might have a problem with the kinking when it comes from the left side. So that's something still to think of and to remember. But with all these configurations, take your pick. They have different pros and cons. Mainly, I think it's determined by stent design. So some stents you might want to do this, the other stents will not work like that. There's absolutely no literature or proof or whatever what works and what doesn't work. It is still something that we really should find out, and how difficult that might be, because there's not that many of those cases, and so many factors play a role. So it will be very difficult, but it's absolutely interesting to talk and to talk about it and think about it further. So the question that I pose. Is there a need for dedicated confluence stent? There's something maybe to discuss. Thank you.
Thanks, Rick. That was really good. But so your current treatment for confluence is actually double barrel all the way up the IVC, or are you having a single stent anywhere within the IVC? So
yeah. So at this moment, I'm really doing that double barrel technique. And I don't have a winner yet. So it also depends sometimes on how do I feel about this? What I'm looking at. Sometimes it's I really like the flaring, for example, of the Venovo inside that hepatic vein. However, I think that the Venovo width is just not big enough. I would like to have it 2 millimeters larger, but still. But I really like that. And I still think maybe it's just me, but I like that picture of a true vena cava, because it used to be a vena cava. It used to be one pipe. So I want to have that pipe again. And this, I cannot really go around it. So my gut feeling says I want to have a pipe, and that just based upon the literature of the early literature and the problems that we've seen with all the other configurations, is that maybe you should think about a double barrel. But yeah, I follow my gut feeling.
Oh, fair enough. What about stenting across the renal veins? Do you have any problems with that?
Yeah, beautiful question, because so many times that there was asked in the beginning, and I was saying, we've never seen anything like that, right? So we never. I actually, honestly, the first 10 cases, I didn't think about it because I think it was occluded. So what's the difference? And because of those questions, we looked into it. We looked into it with imaging. Just seeing that the collateral pathways were just existing. There was no problem whatsoever. And of course, we did some blood examinations in about, I think, 12 patients or something. We didn't publish it. Maybe we should have. But there was absolutely no proof of renal insufficiency whatsoever.
Okay, that's really, really good to know. I mean, if I relate something back to Iman's first talk with inferior vena cava filters and the ones that have been left in and are actually stuck in place, those ones that have caused a thrombosis of the IVC, how have you seen many of these, or how do you deal with patients who have an IVC filter in place that's going to get in the road when you need to stent through an IVC or treat something like that?
That's a beautiful thing to discuss for a long time, because in the United States a lot of IVC filters, right? And pleasure just and we didn't see that many in the Netherlands, and also not in Germany. When I come across one, I always just stented it, go through it and stent it. And I mean, I didn't see any complications of that. That's the first, but it's also not very likely, because if you have that filter in your hand, especially when it's broken, it has nothing on. There's no radio force whatsoever, right? So the big huge stent to go through it, that's not an issue. So I just go across it, and then on Link we saw those tremendous live cases where they go at it for an hour or more with different materials, and to get the filter out in different small particles and everything, fragments, and then say, okay, so nicely done, but what do you do now? Yeah, still you're going to stand it, right? So I think it's I would never take a filter out when it's really embedded. Of course, when there's a filter, you can easily take it out. Of course, take it out. But if that's difficult, just stand across it. I've never seen a problem, and there's absolutely no physics that I can relate to that might cause a problem.
Yeah, Patrick, you seem to be wanting to say something. Did you want to add something to that, or?
No, not at all. I agree with Rick on that one.
Is it for all IVC filters, or only some that you could actually stent through?
I didn't see any difference. I mean, what was the very first one? That awful looking. You get some nice filters now. The very very subtle ones. You have that. Is that the Greenfield filter that really that's close from the top and from the bottom? Just go through it. I just go through it, balloon it till I don't know what I used back then, 24, 26. Just put a large stent through it. Nothing seriously happened. So
as long as you smash it into the side wall, yeah.
Excuse me?
As long as you smash it into the side wall.
Smash it hard and smash it deep.
Okay, I've got a couple of questions to go through before we hit Patrice's talk. There's a question for the panel. How do you select your patients with severe venous disease, C4 and up, for further imaging of their proximal veins? Who'd like to take that one? Anyone?
So the question is how to image. I can actually look.
How do you select your patients with severe venous disease, C4 and up, and image? Which ones do you image more proximal veins? Why would you go up any higher if you got somebody with venous insufficiency, infrainguinal, say? Are there any particular patients that you it flags when you're seeing a patient in your rooms that you go up and image the pelvis or any higher in these sorts of patients? Or would you just treat infrainguinal disease first?
I'll definitely take my ultrasound and go a little bit higher and pretty easily know what's going on. And if there's doubt, I think that there's room for imaging with cross-sectional imaging when you have the slightest doubt that there might be something wrong. But I can relate to the centers that do not have that cross-sectional imaging available the whole time not to do it. I mean, I can just order here and say, okay, I want to have an MRV now, and they will do it. But I can relate to the centers that don't have that, and maybe should be more careful with that. But I don't have an answer for that because I'm just spoiled.
Anyone else, or Patrick?
I mean, one question that Rick, you asked about the height difference in that image. Our fellow Nina Yap did ask me if you were standing on a stool. So I did have to tell her that you weren't. But I'd like to ask you a question in a second, Rick, related to talk. I could ask questions all night from you, but just to answer that question, Steve, I guess one of the things we found in just normal practice here in Melbourne is we have our sonographers, and they will normally have been taught to look for phasicity in the iliac veins, and if there is phasicity, think that the iliac vein is patent. And I think if they, every sonographer is just shown once to look over the right common iliac artery and look for May-Thurner compression. And once they see it once, they see that vein collapse, they're like, that's what we should be looking for. And I think it's a matter of training. So I think our sonographers need to be looking more for this. And yes, when in doubt, we, if there isn't a clear patent vein going up and there isn't reflux to explain the disease, absolutely. The next step for us is either an MRV or a CT venogram, whichever one we can get our hands on.
Yeah, I think that's how we manage it too. Basically, we look at the pattern of the disease. If there's any significant deep venous reflux that we can't explain, if they haven't had any DVTs in the past, the phasicity, or if they've got that pelvic vein overflows type picture where they don't actually have an incompetent saphenofemoral junction, saphenopopliteal junction. They've got a lot of gluteal veins, vulval veins, the stuff that's coming from the pelvis. We then go and look in pelvic vein and we have ultrasonographers who can actually do an ultrasound and look at the size, diameters. They look at the areas of stenosis. They compare one side to the other. Actually, I got that off Laurencia mostly, and I think Laurencia got it off you, Rick. Isn't that correct?
Might be.
Maybe. But it seems to work. And I think the more you look, the more you'll find, actually. I think that's what a lot of us are finding. Well, there's one other question before we move on. Is there a risk of Budd-Chiari if a suprarenal IVC revascularization is done and subsequently occludes?
Depends a little bit, right? If there's a risk, yeah, there might always be a risk. I never seen it, and I do not like to stand across. I do not like, and never did it. Stand across the hepatic veins, stand across it, really, and just at that lower limit. Is it absolutely impossible? I never dare to say that. I never seen it.
Okay, cool. I haven't. Anyone else? No.
No.
One more question is, in cases of both deep and superficial venous incompetence and leg swelling, is there any concerns with ablation and removing the superficial system?
Yeah, that looks like it's a question for me. I reckon the incompetence doesn't bother me. I no longer care about deep vein incompetence. It doesn't do anything. I can't fix it. I'm not reconstructing valves in the deep vein system, but probably the author of the question meant obstruction in the deep vein system. And that would be a difficult thing to answer. If there is deep vein obstruction and superficial venous incompetence, that's difficult to deal with. But incompetence and incompetence doesn't bother me. I just ablate what I have to ablate and open up the obstructed iliac vein. But if there is a deep vein incompetence, I don't care about that. I hope it answers the question.
Everyone seems to nodding there. All right, well, let's move on. Patrice is desperate to get his talk out there, so I'm going to share my screen again.
I'm not very desperate. I'm listening to everybody talking, which is great.
All right.
Let me see where I'll share my talk.
Patrice,
Vascular
vascular surgeon for Royal Perth, Hollywood, and June Dallop. Is that how we pronounce it? June Dallop Health Campus?
June Dallop. I think we need to
Brewery.
spend a lot of time together without drinking some wine. So I can. June Dallop.
We got Patrick.
Can I share my screen there, please? Yeah.
Yeah, I'll get you onto the current results of post-arthritic and chronic venous stenting. So I'm going to get you up and running. There we go. Take it away.
I want to share my screen and then I'll share. Okay. Anybody can see my screen? All right. Thanks a lot to Bud and Phillips, and it was for me a pleasure to be with everybody, Iman, Patrik, and Rick, as well as Steve. And I think this is quite a very big topic, and it's topical, and it can bring some debate. One of the biggest problems that I still remember in 1996 as a registrar general surgery working at Courtescue, being sent to the venous clinic, ulcer clinic, and nobody wanted to go because people were saying that these can be treated conservatively, and that's the evidence they have from the NICE and from the United Kingdom. And then I've looked at the evidence and trying to look at that. One of the problems that we have here, we have two words, is post-thrombotic, which we should separate to chronic venous occlusion stenting. That's I don't have any disclaimer. So the biggest problem is that one of the things is that we need to ask ourselves first what is a equipoise. The principle of equipoise is already very well known. Is that early equipoise that you need to have a trial clinician equipoise, and it's always difficult to meet it most of the time. So there were quite a few people who went in and looked at the biological plausibility in different research. This came from when Tosenovsky came with his papers, and which downplay all the venous outcome papers. But to take this further, it came to the principle of asking ourselves, what are we really trying to look for? So I've looked at a lot of papers on venous disease, and I'm always surprised about the numbers of the patients included in the papers. When I compare to the papers from carotid artery disease, where we have nearly more than 2,000, EVA trials, which have more than 2,000, and sometimes some femoral artery trials, where we have nearly more than 800 to 900 patients. So with less number sample size, you will always come with a skew outcomes and the skew hypothesis that you will be asking yourself. So I went in, and those two publications came in, the Cavent, which basically, and the ATRAC trial. The Cavent showed that additional catheter-directed thrombolysis resulted in a persistent and increased clinical benefit during the follow-up for up to 5 years. However, allocation to this therapy did not lead to better quality of life. And that is where, when everybody look at that paper, they say, hold on. So are we doing things that don't improve people's quality of life? And that's an issue. But then when you go deep in the trial design, there were already a fraud on the trial, and there was a lot of bias. And that's the problem of designing trial when your sample size is too small. The optimal endovascular thrombolytic approach needs further investigation. That's a further conclusion. Then the ATRAC trial came in, and that was a trial that was supposed to answer most of the questions. Unfortunately, this study found that PCDT did not prevent PTS over 2 years as a primary outcome. It does increase measure bleeding. It did not influence health-related quality of life or recurrent venous thromboembolism. It does improve leg pain and swelling over 30 days, and you reduce the severity of PTS. Again, in this trial, there were all the patients were put together in one basket, and that was an issue. Patient selection and patient bias. So I went there, I asked myself when I saw this, this topic is, what can we use as evidence? The only way we can go back to the evidence-based medicine here is to go back to systematic review or meta-analysis review. As we know very well, not when Tosenovsky published his paper, I'm sorry to go back to that, there were plenty of papers that came after that. So it is always in a way call when people go back and look at these studies. So I would probably like you guys to look at two papers if you really want to not to waste your time. There's one by Pengui, Binshamza. They published one in 2019. It's probably the most recent one, and it was an editorial publication for the month or for the year. It was a systematic review and meta-analysis of iliofemoral stent post-thrombotic syndrome. So the key here is that their search was last conducted in January 2018. So of course they will exclude everybody that came after that period. There were no restriction, which is a key on the language or date, but the abstracts that were assessed for inclusion in the studies were as well subsequently reviewed again to be quite strict on what we included in the studies. So there were studies that involve endovascular procedure in the treatment of PTS, studies that involve stent placement in a common femoral, external, and common iliac vein. I won't go more detail, but what is quite interesting on this paper is that they excluded all the patients with acute DVT, or everybody with May-Turner syndrome, or non-thrombotic iliac vein lesions. So the article that had less than 20, of course, were removed, which is the key. So basically, they end up only with 7 studies. They started initially with 1,003, and they end up with only 7 studies. So to tell you that the number of papers that have been accepted for publications, and with really a lot of issues, because all those studies that were excluded, they had quite a lot of fault and a lot of bias within the study itself. So those are the studies that were included in those publications, the 7. And we can see the number of patients again, very small, less than 200 to 500, which is for me of a bit of concern. The mean time from DVT to procedure time in some of the study was not even included. The month follow-up was up to 96 months. None of them had a 5 years follow-up. And when we look at the age, the patient age, there were most of them very young people of less than 50. So this is a grade of assessment of main outcomes. It really helps you to look at the patient, at the paper. You look at the risk for bias and keep the study design. You look if there were imprecision in the study. If the quality, what was the quality of the paper? We can see when we look at all those outcomes here, the quality was very low. And the risk of bias of those papers included was really serious. And that was the procedures details, which I won't go deep in this, and everybody has spoken about this. And they look at the meta-analysis of the main outcomes. One of the issues that was here is what there were quite a lot of heterogeneity among studies, and that already increased your analysis and create some bias on your outcomes of your analysis for your meta-analysis review. So therefore, they conclude that the primary no meta-analysis could be applied, and that's where they did struggle. Look at that. And they found as well that when you look at all those statistical derivations, like the Q statistic test, was defined as very low or in some case very high when they were more than 50%. Anyway, I'll come back to that. They did a summary of concomitant procedures and conservative treatment, which is a key. In some of the publications that were reported, there were 3 of them that were reported. The rest of the publication didn't report anything they did as concomitant procedures, which is a bit of an issue. And then they look at the sign and symptom healing outcomes. As you can see, most of them use the VCSS, and there were some of the publications did the Vilata. And when we look at the PEN score, in some of the publication was before 7, which was used. Only 2 publications use the PEN score. The rest use other assessment methods. So CAP was used, VCS, and CVIC was used. Now, when we look at the pool estimate of primary patency, which is we know would be most likely good, and we can see that the pool patency, when we look at the blue, which I wanted you guys to pay attention, it is around above 60%. But now we need to ask ourselves, this is up to 18-month follow-up. We need to ask ourselves, does this translate to the patient quality of life? And that was the question I did ask themselves in this meta-analysis review. The primary assistant patency was better, and the secondary patency got a bit better. So in conclusions, they concluded that clearly that endovenous iliofemoral stenting should be considered a treatment option for PTS with iliofemoral obstructions. However, the quality of evidence that we have up to date to support this treatment is very low. The endovenous stenting has the potential to be effective, but has a low risk of perioperative complication. Even though the efficacy of stenting for PTS remain uncertain, it has the potential to be safe. There were no major complications. This was a F1 positive, but the recommendation is that we need probably further research with stricter methodology so that we can evaluate the potential role of endovenous stenting for treatment of PTS. So this is the first meta-analysis review. The second one, I'll go quick on this one here. This one here was a systematic review by Seeger and Alan Davis, which we had a webinar together two or 3 days ago. And then there they look at the chronic disease secondary to iliac vein obstruction, which was opposite. And this was published in 2016. As you can appreciate, it went, of course, to the European Journal again, who like this type of publications. Here they excluded all cross-sectional studies. They included all participants of all age suffering from CVD related to post-thrombotic or naval obstructions confirmed on imaging. So the primary outcome was a change in severity in CVD, and the severity outcome was validated with a quality of life score. And this is which is quite a flow chart, which help you to really to appreciate. Initially, there are 2,058 records, and only 16 studies were included in systematic review. And they were all there. I want to talk about it. I want to disturb you guys about all those studies. It would be nice for you guys to go through some of them. As you can appreciate, they were quite, they had the antithrombic regime, which was different from one study to the other one. And the sample size, which for me really of great interest, was less than 200 to 300 patients, which I ask myself why, because we have so many venous cases we do, and then but less studies that we publish. And then when you look at the risk of bias, you can really appreciate that when you look at the green. So when you look at the green symbol, you can see that the yellow is when the risk is unclear, and the green is when the risk is low. But most of the patients had the risk of bias being really high. Most of the papers, exceptionally very high. Now, when you assess those grade of assessment for the evidence of those papers, one can see that the quality of the evidence when we grade them was quite very low, almost all of them, except for one paper, which had it low. Now, of interest on those papers, they recorded the number of patients with the ulcers in some of the publications, which is quite very good. Now, I would go to the stent patency. This was recorded to most of the papers, and the complication was as well recorded, but there were less complications we see in most of the arterial disease procedures. As conclusions, when I've reviewed this meta-analysis review and went through all the data, which I don't want to bother you guys about the data that came in, is that endovenous stenting should be considered as a treatment option for obstructive CVD. But to date, the quality of evidence to support its use is still very weak. But consistent effect and marked change in disease course with a potential impact on quality of life still remain promising. So they came again to the conclusion of this review has highlighted the important areas for development of the evidence base before the practice is more widely rolled out. So as you can see, this is clinician practicing in the United Kingdom, and they've reviewed all those data, and then we can't ignore this, unfortunately, we can't. Thanks.
Thanks, Patrice. That was really good. I gave you that talk specifically because I knew you'd be able to get your head around it, and you're very good with figures. So it wasn't actually meant to punish you.
No.
So take it as a compliment.
No, thanks.
I think you did that very well. Thank you very much. I mean, from what you pointed out, we can see that the interventions that we are actually doing, yes, there's not a lot of data out there, but we are making an impact upon patients' quality of life. Is that a true statement, or do I need to validate that in any way?
Yeah, I think all the publication, unfortunately, the quality of life was not well recorded. When I look at them, and then I know that Patrick published his papers with his quality of life, which has improved. But those people, those are some of those publications that were included there. Unfortunately, the quality of life was the biggest question in most of those publications, and that is the key. The stent patency was great. It was good outcomes. Unfortunately, the quality of life was not improved for most of those patients.
What do you think, Rick? I mean, about the current results out there for extending chronic obstructive disease, obstructive venous disease?
So in the meantime, I'm trying to answer a question, but I can do that directly also. Of course, the problem is that so many centers don't do it really structured, right? So according to a certain protocol, we don't know exactly what we actually comparing. So it's, of course, you cannot have that level of evidence that we need to really convince our colleagues. And I'm continuously also here, especially here, I think I'm confronted with that they say, oh, it's still experimental. So it's not experimental after 20 years of doing it all across the world and thousands of patients with similar results. But if you really think only very narrowly, and you think about randomized controlled trials and that level of evidence, yeah, it's going to be difficult. I know that at Maastricht, where I used to be, there's now 3.5 years, I think, almost 4 years, they're trying to fill a RCT, and I think they're still not done. So I'll ask in a minute if maybe she's online how that's going. But there were not that many patients. I think 120 patients or something. So we have the randomized control from Brazil, but we really need something better. And but it's very difficult. It's multifactorial, and I think that we need quite some extra data to really be convincing, but not for us guys. I mean, we know what we're talking about, and it's so obvious that it's a good treatment, that it works, that the patients do principally get better. I mean, 90% really, of the PTS really is getting better, and very, very few patients, I used to say none, but very few patients get worse. And the only thing that we should really concentrate on, I think, is May-Turner, because May-Turner is something, I mean, we checked that also, but 60% does better and 40% is lying there, right? So how to really find those significant patients, those specific patient group that we can help. That is, I think, the main goal. That should be a main goal.
Yeah, I think we've got the same problem here in Australia. We've got a couple of camps. We're all vascular surgeons, interventionists, and radiologists who deal with venous disease. However, there's a group of us who do it, and there's a group of us who believe in it, and then there's a group who don't do it and don't believe it, who just like to diss us at any occasion. And I think the most important thing here is that the people who do it are seeing that we're making a massive impact upon our patients' quality of life and their swelling and their ulcers, and also that we're not doing anything that's really deleterious to them. We're not hurting them in any major way. And we're doing everything that we can to minimize any risks associated with any intervention. And we've seen from the results that the results are pretty good, but we still have a long way to go out there to get significant level results, which can be accepted by the whole group. I don't know, but maybe we should be thinking about having, I'm just thinking out there for our ANZ SVS group, because we've got an AGM coming up next weekend, but maybe we should have a subgroup of just venous interventionalists who can come to a consensus. I don't know. I don't know. Maybe it's the same overseas.
It grows really, really, really slow because it's all on an individual basis. You know, I have some really tough critics, and they finally do send a patient, and they see how well it goes. And certainly it's like, oh man, I never knew that, and we're so amazed about it, and everything's open, and patients doing better, and blah blah. So and now they're sending patients, you know, from 300 kilometers away. For Germany, that's quite large. For Australia, it's nothing. I know. You know, and then you had another small winner, but I need to convince every single venous clinic, every single venous superficial venous specialist. I need to, you know, it feels like every time that you win one, you know, you really have to work for it every single time.
Yeah, we really do have to educate the so-called educated people. Even about May-Thurner, there's a lot of people out there who really don't understand that in the very beginning.
What is each of the panel think? I have a question here that has been asked to us several times. Is that a patient who doesn't have, I think Iman touched that, who doesn't have infrarenal atresia of IVC, so he does have a good IVC, and he develops a iliocaval thrombosis. Why the patient who doesn't have any thrombotic problem will develop an iliofemoral DVT versus someone who develop only a iliac DVT. So what is the pathogenesis underlying those? Those are the questions that were asked in one of the session meetings. So the reason for that is that when they look at the actual trial is that everybody was put in one basket. It was quite important to remove people from the same basket and differentiate the disease. So I don't know what the panel think about that.
Iman?
I can certainly kickstart the answer, and absolutely, Patrice. I mean, this is a curious thing that sometimes the May-Thurner clot stops at the May-Thurner, and sometimes you see a tongue of thrombus going up into the IVC. It's hard to see. Obviously, there's that double hit system. So either there's an IVC abnormality, and then there's a secondary hit, which could be a procoagulant state. It could be external compression. It could be patient immobility, etc., that causes that clot to form. So that's the DVT as a whole. But why it would extend up the IVC if the IVC is completely normal, perhaps may have to do with the clot burden in that limb and what the original cause for that iliofemoral DVT was. What I know for certain is that that's the first thing that I go for to clear, is to get that IVC thrombus cleared, and then focus on the common iliac and work our way back down. Those are my 2 cents on it, but what are the other thoughts?
Patrick, what do you think about the other question was asked? It was age and weight. Do you think that age and weight do impact? Because most of those patients are younger, and in some of your group of patients you have, they're quite overweight. Do you think that do impact on the outcomes of those patients?
Yeah, absolutely. I have shifted, as you probably know, from arterial to venous practice, and from thin smokers, I have shifted to overweight whales, right? So I treat patients who are body mass index 40 plus, and they present even without any history of DVT with ulceration. So I think the obesity is the independent risk factor for high venous pressure or venous hypertension, let alone other risk factors. So if they have a prothrombotic condition, they'd be more likely having extensive DVT because of the combination of prothrombotic and obesity. So every third patient of mine is obese. So I think there is a risk. That's the short answer. Yes.
Rick, what do you think about age in the German population? Does most of your patients are less than 40 that you treat, or? over the age of 50?
I think that most patients are younger than 40, but just, I'm treating a little older generation. That has to do with what I talked about before, that you need to convince those physicians, and they tend to send then their most awful patients, so they're already in the practice for a long time. So that's a little bit skewed. But I totally agree that those are young patients usually, that there's some kind of decompensation. They have all the collateral pathways, and they're working out fine. There's some kind of decompensation. I usually talk with the patients, and they say something like, I started doing something different in my life. Started to do heavy weighting, do more fitness, do less fitness, do whatever. Starting a new job. Usually a moment that turns to be a thrombosis, or that thrombosis developed, and thereby the acute complications start, to acute complaints start, and then we do the imaging, and then we see the underlying problems. But it's as Iman said, it's usually asymptomatic, and it's some kind of decompensation occurs, and then the patients come to me, and usually that is between 20 and 40.
So do you think that there is a place here to set up a large registry or RCT, like we have it in aortic aneurysm, carotid, and femoral SFA? Because there is quite a room, there's quite a lot of patients we are doing. The only way we can capture this by having because I've looked at the vernacular study and some of those studies, they still have less than 300 to 400 patients. And I think the opportunity is there to really capture all those informations in a good registry or RCT.
Well, just first, I'd like to give you an update on that RCT that I was just talking about. They included 60 patients of it is at 120, and it was started in 2017, so 2018. So it's really, really going slow, and that also has to do now with that it's especially those patients that actually find a doctor that can help them, right? They want a treatment. They expect a treatment. So, and therefore they don't want to be in RCT. They don't want to wait another year. They know that there's a possibility. They've been told for years and years, there's no way we can treat you. Just learn to live with it. And now suddenly they can be treated. And then okay, but 50% chance because maybe you have to wait another year. So they don't want to do that. So those RCTs are very, very, very difficult to fill. So registry, I've been trying to propose for a long time. I think it's a brilliant idea. I think it used to be easier with less stents on the market. So it will be difficult to find a common path in one way. On the other hand, if all those stents available will lead to similar results, and different techniques will lead to similar results, I think that's very valuable. So in short, I'm very much in favor of a registry intercontinental. Yeah.
Can I just, how do we institute that? I mean, we need to have somebody who's going to help us put it together. I mean, is this going to be an industry-based thing, or is it going to be physician-based? I mean, that's what we
talked for a long time. I think that somebody should, start it and get the industry on one table, and they all have to work together, because it's going to cost a lot of money, and every company will benefit from that. So they all have to be on the table, and they all have to participate and put in a lot of money, and then there will be no bias to one stand, another stand. So absolutely, there will be the solution. So
yeah, and we'll be able to treat these cases with data behind us.
Sorry? Again.
And we'll be able to treat these cases with a lot more data behind us.
Absolutely.
Yeah. Absolutely. Oh, look, I'll just move on to, there was just a couple of things. There was a question asked Rick about anticoagulation following these sorts of things. I'll just mention his answer, which was regular DOACs for 6 months. and used to recommend lifelong. But I'll get you to hang over that, because Rick's coming back next week, and that's going to be one of the topics that we're going to be talking about, anticoagulation versus antiplatelet agents. So, and we'll have a hematologist on board to help us assist with working that out. So that'll be fun. And one of the other questions was that it was actually directed to Patrik about endophlebectomy and the use of arteriovenous fistulas. And I'm going to hang over on that question too, because this endophlebectomy is going to be a topic we're going to be talking about in our next session again. So we'll be able to move on to those sorts of questions in a couple of weeks. So that'll be great. So look, I'd like to wrap it up there because we've gone over time, but I'd like to thank everyone involved, especially BD and Phillips again for putting it on, and for all of our panel. We've got Rick and Patrice, Patrik, Iman. Everyone's been absolutely brilliant putting their talks together, and there's been a lot of discussion. So I just think we should continue with this, and maybe I really think we need to put up a subgroup for our own society. But anyway, that's something else to talk about at another time. So we'll call it a day there. I'll just share my screen one more time just to show you what we're going to talk about next week. This is, in 2 weeks' time. We've got Scott Dunkley talk.
Could you say?
I've got Siri talking to me in the background, sorry. We've got Scott Dunkley talking about anticoagulation versus antiplatelet agents. We've got Ramesh Tripathi talking about endophlebectomy, and I think his topic is about whether it's dead or not. Phil's going to be talking about novel interventions with chronic venous occlusions. And Rick, I can't remember what we've got you talking on. Do you remember?
Sorry, I didn't quite catch that. Could you please repeat it?
So that's going to be exciting. So we agreed on ancillary methods to support the endovascular treatment. So
that's right.
Think about that. It nicely fits together with the AV fistula that we're pushing to 2 weeks. So yeah.
Brilliant. All right, well, let's wrap it up there. I hope to see everyone again. The session 4 will be on Wednesday, the 14th of October, again, starting at 7 p.m. You now know the panelists, and I look forward to seeing you all then. Thank you again for participating.
Beautiful.
Thanks a lot.
Thank you. Thank you, everybody.
Great.
Thank you, guys. Thank you.
Thanks. Take care, guys. Be safe.
Okay.